they have that in common, that when people with Tourette's engage in tic behaviors, what they're really doing is they're sort of, metaphorically speaking, scratching an itch. There's an urge that precedes the tic behavior. They engage in the behavior. That urge subsides. With OCD, it might be more of a sensation or a thought, right? So the common example might be, I touched something that my mind tells me might be contaminated. That thought causes me a great deal of anxiety, and so I engage in some kind of safety behavior of excessive washing or perhaps avoiding touching things, and then the anxiety may subside, right? So it's a similar mechanism, right, that we engage in behaviors aimed at alleviating uncomfortable sensations or thoughts.
Welcome to the UpTick, brought to you by the New Jersey Center for Tourette Syndrome and Associated Disorders, empowering children and adults through education, advocacy, and research by sharing the stories and experiences relevant to the TS community.
Welcome back to the UpTick. I am here with Dr. Robert Zambrano. He's a clinical psychologist and cognitive behavioral therapist in East Brunswick, New Jersey, and he specializes in Tourette, anxiety, and OCD. Dr. Zambrano, it's great to have you here.
Great to meet you, Michael. It's a pleasure to be on the program.
Would love to hear a little bit about how you first got into the Tourette space.
Yeah, it was really unexpected in my life, actually. I remember in grad school, of course, like most psychologists, learning about Tourette syndrome as just an interesting part of the DSM and not really getting a whole lot of training in it at that point. I don't think our program really had much to say other than this is what Tourette syndrome is. I catered my career. I sort of was really interested in the niche of OCD. That's been something I've always had a passion for treating. And as a cognitive behavioral therapist, I really love that there are evidence-based therapies that we know are really effective for helping people with OCD. So that's always been something I've been attracted to, just the idea of sort of following treatments that the research says this is the way to go. And at the time, cognitive behavioral therapy wasn't as popular as it is now. So it was really a nice time in my career to carve out an area where I was sort of well known for being the guy in my year of school who was really interested in that, like super passionate about it. So fast forward a few years later, I had just left working at a psychiatric hospital in Secaucus that I really enjoyed working at, but pursued my dream of working in a private practice. So I joined, it's been 18 years now, the practice that I'm working at now called Stress and Anxiety Services of New Jersey. And at the time, it was taking a little bit longer to build up a caseload, right? And so most of us in the world of private practice know that you get paid per the amount of clients you see. And I was in a relationship with somebody who I was very interested in continuing that relationship with. And we were living together talking about marriage. And so I said, all right, let's get moving with this. But I need to make a little bit more money because engagement rings and weddings are no cheap thing. So I kind of put the word out there that I was looking for some extra part-time work, not hearing a lot. And then one of my mentors from my grad school, Dr. Lou Gantwerk, sent me a random email one day, said, hey, I heard you were looking for something here at Rutgers and you're in the graduate program that I attended. We're actually looking to add somebody to work with our Tourette syndrome program. They had already had somebody well-established who really knows her stuff, Dr. Lori Rockmore, shout out at Lori, here's this, who was heading up that program, but they wanted to add another licensed individual to the staff to help out with having that program move forward. So I said, great, wonderful opportunity. Problem is I knew nothing about Tourette's. Lou said, you'll be a natural. You're an OCD guy. We remember that this was your niche. This is something that you're really passionate about. And there's a lot of overlap. And it did so happen at that point in my career, because our practice is really well known for treating OCD, that I was seeing a lot of OCD cases and starting to see a few Tourette's cases here and there. Even though what we know is most people with OCD don't have Tourette's, a lot of folks with Tourette's do have OCD. So there is some overlap there, neurologically speaking. And so if you treat enough OCD, you're going to see a lot of Tourette's over the years if you do it long enough. I said, sure, why not? It'll be good just for my private practice work as well to learn more about this disorder. So I joined. And the funny thing was the first day of my training with Dr. Rockmore and hearing from, some of the big experts in the field, totally blanking on the name right now, but we had a big time speaker. I was really excited to learn more about Tourette's and work with Tourette's. The day before, the person who I was hoping to buy an engagement ring decided that she maybe wanted to end the relationship instead. So that was a sad but weird origin to my introduction to Tourette syndrome. I was really just looking for another gig. to make a little extra money on the side. But, well, two wonderful things came out of it. Number one, I eventually met and married a different woman who I'm still married to today, and very happily so. We have a lovely, amazing family. But the second wonderful thing that came out of it was really sort of getting in contact with an amazing community and learning about, I think, really at the time, and hopefully less so now, an underserved population of folks with Tourette syndrome. So it was really just fascinating to learn more and more about effective therapies for people with Tourette's. And away we went. So I worked at the Tourette syndrome program at Rutgers University for a few years. And then as my caseload built up, I had to make the difficult decision of leaving the program so I could focus a little bit more on my private practice work. But I, to this day, continue seeing a number of folks with Tourette syndrome. Typically, most of the time, they come through the door during their elementary school years and into their teenage years. But every now and then, we'll get an adult as well who comes in who would like to learn a little bit more about managing either verbal or motor tics.
You mentioned the co-occurrence of Tourette and OCD, and as many of our listeners know, around 50% or so of people with Tourette have OCD. So I actually should ask you, you probably know the updated stats on that. How prevalent is OCD in the Tourette community?
And what I've seen, it's pretty steady around those numbers, right? So depending on what study you'll see, it's usually hovers in the 50, 55, 60% range. But over the years, it's stayed pretty consistent in terms of that's the overlap that you tend to see.
Do we notice any differences in OCD when it is coming along with Tourette versus OCD as a standalone condition?
I mean, I think as with lots of things with Tourette's, it's so idiosyncratic, right? So it depends on which person you're working with. So I would say, in general, when I work with people who have both Tourette syndrome and OCD, the OCD isn't radically different than a person who has OCD that doesn't have Tourette syndrome. There can be a lot of overlap, right? In terms of Tourette syndrome, sometimes people refer to something called tourettic OCD, right? In other words, that's an OCD that's based on doing things in a way that just sort of feels right, right? So it's not that sort of rhyme or reason that we get with a lot of OCD, as in like, I tap something 3 times and almost as a superstitious kind of act, then my intrusive thought goes away or at least subsides because I've done some sort of compulsive behavior aimed at alleviating the anxiety. With tourettic OCD, it's almost like I do something until it just sort of clicks. And so it's a different mechanism for alleviating that anxiety, but it is repetitive in nature, and it still has the same goal of sort of, again, alleviating anxiety. And I think that's kind of common as an overlap between OCD itself and Tourette's. You know, as two completely distinct disorders, we can say they have that in common, that when people with Tourette's engage in tic behaviors, what they're really doing is they're sort of, metaphorically speaking, scratching an itch, right? Mm-hmm. There's an urge that precedes the tic behavior. They engage in the behavior. That urge subsides. With OCD, it might be more of a sensation or a thought, right? So the common example might be, I touched something that my mind tells me might be contaminated. That thought causes me a great deal of anxiety, and so I engage in some kind of safety behavior of excessive washing or perhaps avoiding touching things. And then the anxiety may subside, right? So it's a similar mechanism, right? That we engage in behaviors aimed at alleviating uncomfortable sensations or thoughts. But in terms of, again, your original question, is there a big difference in between the OCD that people with Tourette's have versus the OCD people who don't have Tourette's has? Not necessarily. What we might find is a lot of folks with Tourette's may have a little bit more difficulty with frustration tolerance. They may have a little bit more difficulty with impulse control. So it's really hard just from a plain OCD perspective, right? Where we say we're asking somebody to tolerate discomfort. So the therapy, as I'm sure a lot of your audience has heard, the main therapy, what the research backs for years and years and years, is what we call exposure and response prevention treatment. If you've been in the field longer, like someone like me, the old literature would call it ERP. You see more and more these days people calling it EXRP. But in both cases, it stands for exposure and response prevention. So ERP is essentially whatever it is that might trigger that uncomfortable OCD feeling, we're going to trigger it on purpose. And then we're going to train people to suppress the response, the compulsive response that's aimed at alleviating that anxiety, and instead teaching them to tolerate, to sit with these temporary, but perhaps very intense and unpleasant feelings, right? Now you take a person with Tourette's who might have a much harder time with that. Again, maybe lower frustration tolerance threshold, might tend to be more impulsive in some of their behaviors. That might be a more difficult protocol to execute, the response prevention portion of it. the triggering we could trigger anybody who has OCD. Yeah. It's getting them to sort of withhold that response. I'd say that would be a difference that you sometimes see, not always, but sometimes see in folks with Tourette's, that it's a little harder for them to resist the compulsive behavior. But on the flip side, somebody who doesn't have OCD, who just has really intense OCD, might report the same thing.
I'm curious if you can elaborate on that, on the treatment of more of that tourettic OCD.
Sure. With a tourettic OCD, so I'll give you an example of somebody who I worked with many years ago. Their tourettic OCD was not thought-based. It wasn't, I need to do this or else something bad will happen, right? Which is very common with OCD.
Right.
So again, I need to wash my hands or else I'll get a disease or I'll just experience disgust. Tourettic OCD might be more along the lines of, I just have some sort of sensory experience, some sort of urge that I can't quite explain. Different than OCD where there's an idea or a thought behind it, right? And then I might try and eliminate that urge by engaging in a just right kind of behavior. So the person I worked with years ago, I remember, would suddenly look up in the corner, right? I'm doing it right now. And then I would see them tracing in a certain way. And they would explain, I don't know why I have to do this, but my eyes have to go and trace the room, right?
Yeah.
And if I don't do it right, I just have to keep doing it. And you might even ask that person, well, what does doing it right mean? And it wasn't like I had to do it 3 times or I had to do it precisely.
It just feels right. Like your brain just tells you when it's good.
I don't know when it's right, but I feel it. I can't explain it exactly. It just sort of clicks at some point. So tourettic OCD really behaves like that. It tends to lack ideation, but it has a certain kind of just, I don't know what it is, but I'll know it when I feel it. And so the therapy for exposure and response prevention would be very similar to what we would refer to as habit reversal training when we treat people with Tourette syndrome. So it might be when you catch yourself starting to trace, what would be a competing response? So if your eyes want to go right slowly, maybe it would be, let's close our eyes, right? Because now we're not able to fulfill the compulsion because our eyes are closed and our brain says, I have to see a thing a certain way. Or if the person closes their eyes and they say, but I can still feel my eyeballs moving. As simple as it sounds, it might be, if your eyes want to slowly move to the right, what can we do differently? Ideally, it would be, let's instead hold it towards the left. If my eyes want to move that way, I'm going to make my eyes go that way. So it's almost like this tug of war that happens in our brain. And we're trying to just wait out the urge. Urge has passed. Okay, now I can just go back to not fighting anything. And so that's a competing response. Some people might have a harder time doing that. So we try and maybe loosen up the rules, so to speak. So let's say if their eyes want to trace that way, but slowly and precisely, I might say, well, let's do it fast. Let's just whip around the room. We're going to sort of put our brain on notice. We're going to prove to ourselves that I don't have to do what my brain tells me to do. I don't have to do it exactly how it's trying to get me to do it. And then slowly but surely, we can get them to resist more effectively. And with any luck, then we're not reinforcing the habit and the habit sort of dies out.
It's interesting to hear because I imagine if I had this, putting myself in the shoes of that person, that patient, and if you told me to quickly zip my eyes from place to place, point to point, I would probably say, oh, I'm doing it and the urge isn't going away. It doesn't feel just right. But I guess what you're saying is over time, habitually, your brain might change and evolve on that point. So really, it's a lot of the same things we would use for a tic.
Sure. And the important thing is we want to tell our clients, like, the goal isn't for the urge to go away. Good news is it will anyway, because everything is temporary, right? There's never been a thought, a feeling, or a sensation that was permanent. Now, it's easy for me to say because I'm not dealing with the intense discomfort of not engaging in the feeling. So somebody might, after a minute, say, I'm doing it and I don't feel any better. And I get it. I get why they want so badly to experience that relief. But at the end of the day, we're still trying to teach them that at least a fundamental building block of this process is to say, we're going to prove to ourselves that we don't have to do what our brain tells us to do. And that maybe it will feel really uncomfortable. And that's okay, because then we proved ourselves that we can do uncomfortable things without having to give in.
One of the hallmarks of habit reversal training is that eventually you get to the point where you learn how to do this, how to make competing responses so that you can practice on your own. You can do this at home, right. Integrate it into your life. It sounds like that's also kind of a goal of this as well. It's, not just something we're going to do in the therapy session. We go home and then can practice it and continue, because that's how you make it a habit. Absolutely. Is that fair to say?
Absolutely. One of in our practice, I think a lot of us, our training method is to teach people through metaphors and stories, right? So one metaphor we use is it's really good if you want to get in shape. If you want to hire a trainer, that's great. Trainers introduce structure. They teach you how to do things. They teach you how to do them right. But if you then spend the rest of the week not working out, you're probably not going to get a lot of results. In fact, probably the trainer might have been a waste of money and time. I mean, I'm never going to knock going to the gym once a week, but if we're pursuing certain goals, we understand it's got to be done consistently and more than just once. So I think that fits with this model. Again, the difference between, I think, OCD and Tourette's is the expected outcomes are kind of different as well. In other words, with my Tourette's clients, we really do kind of talk about this is part of how your brain functions, and that's okay. And that what I'm trying to teach you to do is how to manage this when you choose to manage it. Part of my job is also educating families about, it's okay for your kid to take it home or in private spaces because holding it back is really uncomfortable. And that's all right, because we're probably not going to extinguish Tourette's via habit reversal training or exposure therapy. This is just part of their neurological mix, and we're teaching them these things, maybe if we're lucky, so they don't happen as often as they have been, or more practically speaking, in terms of we can maybe learn greater controls so that we can pick our spots. So we can say, in a situation where I want to manage the tic, I can use these techniques I'm learning in therapy. Whereas with OCD, we might have slightly more ambitious goals, right? To be able to say, if we do this consistently enough, this exposure and response therapy treatment, that we might get to the point where the urge or need to engage in the compulsive behavior might extinguish, right? That doesn't mean we've cured the OCD, but it may mean that we get to the point where the symptom that you're in treatment for isn't that meaningful, isn't causing much disruption, right? I do sometimes with my clients say, almost in a tongue-in-cheek way, that I can cure the D in your OCD.
Yeah. It's not interfering with major life functions anymore. You can go about and do your thing, live your life.
Exactly. Yeah. So we emphasize, well, what is the D, right? So it's a disorder. It causes dysfunction. It causes distress. It causes delay. All those Ds are important. And so if I can teach a client to get to the point where, yes, I still have these thoughts, maybe even these thoughts produce uncomfortable feelings that I wish were not there. But if I'm at the point where I'm not delayed by them, I'm not distressed by them, it's not really interfering with daily functioning, then that's a point where we say, you've really done something important and meaningful, right? This is no longer having the same kind of control over your life as it used to.
Yeah, really got took away the disorder part of it. Now it's just your brain. This is just something it does, and it's not causing major problems in your life anymore.
Right.
Now, the other challenge that one other challenge a lot of people in our community face is anxiety. And right. I know this is also an area where you have a lot of experience with in the clinical side of it. Anxiety, as many of us know, can make our tics worse. And I'm curious how you would approach that with a patient.
Absolutely, especially with a Tourette's patient. When I start working with a client, I want to make sure that we are optimistic, but also realistic. And so what that means is that not everybody is going to experience very significant reductions in tics. For whatever reason, some people don't benefit as much from habit reversal trainings and what we call CBIT for Tourette's. But what we do know is sometimes there's actually more bang for your buck in terms of managing the anxiety that may be exacerbating the tics. As a cognitive behavioral therapist, folks who do CBT, when it comes to anxiety, one of the main tools is what we call cognitive therapy. So it's really helping a client identify what is it that we're telling ourselves that produces the emotional response that we're having. So very commonly, to introduce that concept, when I first start working with people, I kind of tell a silly little story that I've been telling since I was in grad school, so over 20 years. I'll include you in the story, right? So let's imagine that you and I have never met each other, that I'm a complete stranger to you. And I'm sitting at a Barnes & Noble's reading a magazine and drinking a cup of coffee. And then you walk in and I look in your direction and I make some kind of face. Now, we're going to assume I don't have a motor tic in this situation, but a lot of people might have an emotional response to that stimuli occurring. I'll put you on the spot, Michael. What do you think? What emotion? And by emotion, I usually mean like a one word. So not a thought, but like a feeling. What feeling do you think you'd be experiencing in that?
Self-conscious or embarrassed? And that could be me. I would, what is it? Is my nose bleeding? Do I have my face? Like immediately I would go into kind of a defensive.
You're doing a great job here, right?
My reaction would be, what's wrong with me?
Right. So exactly. So you might your personal style, how your brain functions, it might say, oh, this guy is looking at me and making faces at me because he doesn't like how I look or something embarrassing about me. Maybe there's a stain on my shirt, right? That would be your thought. And that thought, the natural conclusion of that thought is, I feel embarrassed or I feel self-conscious. The person who feels anxious, it's the same exact stimuli. I tell the story the same way every time. The person who feels angry, I like to think of it as a default New Jersey emotion. The person who feels angry might have a different set of thoughts, right? So who is this guy? What right does he have to look at me that way? He's being a real jerk, right? I should put him in his place. So that would produce that thought. Now, somebody who feels scared would have a different set of thoughts, right? That person seems dangerous. That person might want to harm me, right? The person who feels sad would have a completely different set of thoughts. That person is judging me. That person doesn't like me. He's just like everybody else who doesn't like me. I feel so ashamed of myself. I'm so sad about this, right? So we could go on, but the point is that any emotional reaction that we have is a byproduct of what we tell ourselves. With anxiety disorders, one of the building blocks that we like to teach our clients is let's learn to sort of identify what it is that we're telling ourselves. But let's also understand that our feelings are not facts and our thoughts merit exploration. So let's say if you came into the therapy room and you were telling me, oh, this guy looked at me at the Barnes and Nobles and I'm so upset because, I'm sure I must have done something to embarrass myself and he must have thought I was so weird. Well, I would encourage you to look at what else could it be. In fact, you already did a good job, right? You identify, well, maybe he was thinking something else. Maybe he looked at the clock on the wall and realized that he's running out of time and hasn't finished his coffee. So that face was disappointment. It had nothing to do with it. Now, I also tell my clients, and maybe you were completely right. Maybe what you were thinking was true. He was judging you. He did think your shirt looked ugly or you had a weird stain on your shirt. And he was laughing at you internally or disgusted with your appearance, right? Those things can be true, but how do we know? Right. So we want to help people be really open-minded to there could be other possibilities. And that's one branch of cognitive therapies. We say, okay, let's talk about what evidence, what information do we have that would lend us to believe that your hypothesis is accurate? And is it possible that there's other ways to look at this? My clients generally like doing that better than the other part. But I think the other part is really important, which is, what if what you're thinking is true? Right. So what if that person was judging you, Michael? What if he did think you looked silly and gross with that big old stain on your shirt? And usually, so that's, we start to ask what are called Socratic questions. And this is where the psychologist gets to play dumb and try and dig deep, help the client dig deeper. We sometimes refer to this technique also as the downward arrow. Let's go underneath the thought. And okay, why is that thought important? And so that helps people identify their beliefs. And then the more consistent they are at identifying what they're telling themselves, how it makes them feel, what distortions in thinking they might be having. So I might teach somebody, it sounds like you're doing a little mind reading. You're acting as if you know what the person is thinking when we really don't. Or maybe we're doing some magnification. Maybe that guy did think your shirt looked ugly. Is that really that important? What do you think? And they might tell me, they might defend their position a little bit. Well, here's why it's so important. And then I just keep asking them more follow-up questions. It's not my job to tell them that it's not important and you need to get over it. It's my job to help them sort of reach healthier thoughts that maybe are in line with their values and what they think is really important. But then my job is to have them not sort of accept their beliefs without maybe investigating them a little bit. Now, the B in CBT, that's behavioral. Sometimes that, again, involves exposure therapy. So if people are really anxious, let's talk about a common anxiety that people with Tourette's have. What if these new classmates, I'm going into middle school, and what if none of them know what Tourette's is? And I start making all these noises or having all these motions. What if people start to judge me? What if people are mean to me? Again, we could do some cognitive therapy where we talk about, okay, what if? How likely is it? What's happened in the past? What would you want to do? What is your game plan if someone is rude or disrespectful to you? But we can also talk about, okay, that's a legit fear. People in middle school can be mean. Somebody might make fun of you. What's a good way to sort of manage this? Now, sometimes I try and suggest to clients, maybe we're going to have to educate others about what Tourette's is. Hey, I have Tourette's. It's not my fault. I make these sounds or have these motions. I can't control it. It's a neurological thing. It would be really cool if you guys would just ignore it and leave me alone. So many of my clients over the years have said, I'm not doing that. That's embarrassing. And sometimes even the parents don't want to do it because, well, now my child is being labeled I get it. I get it. I don't know if I was that age, if I would have wanted to be labeled and have to publicly announce or explain to people what this is. But what we also find is that is a behavior, that is a choice that for a lot of folks makes actually a dramatic difference, right? Now we don't have to spend all day worrying about what if somebody notices, what will other people think? Now we actually have some agency in that process, right? I can teach people what this is.
Very empowering. Yeah.
If we're really concerned about like, people are going to think I'm doing this because I'm attention seeking or trying to be weird. Not that the person with Tourette's owes anyone an explanation, but I think part of diffusing that particular anxiety is, again, getting ahead of it and being able to say, hey, this is the thing I do. Please take it or leave it and be kind. And now I can take the pressure off of myself to have to control all these things when maybe what's more effective is letting folks know it is what it is. And I'm going to hope that you can accept it and ignore it.
I like the way you worded some of that, of like getting in front of it, getting in control of it, or getting to the forefront of it. Because,
right.
I think, at least for me personally, a lot of my anxiety is sort of, it comes around fear of the unknown, or like, I don't even understand what's going to happen next and how I'm going to react to it. And it's all just kind of this vague, overwhelming mass of like, so when I break down, or a therapist and I would break down, okay, what are my worries? What could happen? And then let's play out each of those if they were to happen, or if they don't, you've just given me kind of a map of what is all going on. Right. It gives me that visibility, and I think that clarity, because it's really just not knowing that's what scares me.
It can be so scary because there's so much. In fact, if we're honest with each other, with ourselves, right? Most of life we have no control over, but we also don't want to forget that we do have control over ourselves. We still have free will. We could still make choices. And so that's why it's really important to talk about, yes, I can't control what the kid in your middle school class is going to say to you, but you can control how you respond, right? Now, that's different than react. Our reactions are sort of instantaneous, right? So my instant reaction might be, I feel sad, I feel scared, I feel angry, right? That's an emotional reaction. But we have free will where we can choose how we respond. And so part of the process of therapy is helping people decide, how would you like to respond? Even if it sounds unrealistic, even if it sounds like, I don't know if I could do that. Well, then great. Let's role play it. Let's practice it. Let's do it on smaller scales so that you're really sort of training yourself. Okay, I do have some agency when it comes to dealing with my anxiety. There are things I can do that are healthy. I can't guarantee the results, but it's good to at least know that I'm not helpless.
Mm-hmm. Yeah, you have agency in this. There are things you can do. Yeah. And you will do something, when that time comes.
I think one of the other really cool things about cognitive therapy that I really enjoy is that the more people get in touch with, understanding that I have a brain, my brain thinks thoughts that I can't control, that this is true of every human being, the two of us, right? Whatever thought pops into our head, we didn't ask it to show up, that it's there. And I try and teach my clients that, hey, because we all have brains and our brains have been absorbing experiences for our entire life, that the thoughts we have are not within our control. So the way I think about the world, the way I react to things is a byproduct of my gender, is a byproduct of the part of the world I'm from, New Jersey. So maybe I have the tendency to sort of view things aggressively and get angry. The era that we're from. I was born in 1976. So growing up in the 80s and 90s maybe gives me a different view of the world. I am a first generation American. My parents are both from Colombia. So maybe those life experiences, the religion I grew up in, the people that I encountered in my life, all of those things come together and determine why I think the way I do. But it's not up to me how I think. That just happens randomly. So the more we do cognitive therapy, the more people become aware of like, oh, wow, I'm really learning like what my thoughts and beliefs are. The more we can just notice them and not be controlled by them. So when I feel irritated or upset about something, I've gotten so much better as I've gotten older. So of just noticing, and almost, I know this is going to sound weird, but I do think, I try and teach my clients to think this way. I try and teach myself to do this. I'll just notice, I'll say, I notice my brain is getting irritated about something. And I remember that most of the time that my brain gets irritated about something, it's usually something that's kind of silly when I think about it afterwards.
Yeah.
Right? And it's super liberating, right? Like I don't have to react the way that I always reacted. I can just go, okay, that's just what my brain thinks. I can notice what my brain thinks and I can just let it go. I can move on. Unless it does, like some things, of course, require action and responses. But most of the time, it's just like, you know what? this is just my brain saying stuff. I don't have to pay attention to it or take it too seriously.
This point here was such a powerful coping mechanism for me in dealing with impulsivity growing up. Like a lot of people with ADHD and Tourette have challenges with impulsivity. And I think for me, not an issue anymore, but I think I was really able to manage it better when I got to a place where on my good days, I get a thought that comes to my head suddenly. And I there's something so powerful about being able to acknowledge it as a thought and then say, like, what do I want to do with this? Do I want to unpack it? Why do I feel this way? Do I want to just blurt it out and say it? Do I want to maybe wait a minute and then say it if I still feel like saying it? And I found it was so empowering when I realized I don't have to say the thing, the first thing that comes to my head. I can actually sit on it and then make a decision later. Easier said than done, but I think there was some kind of growth that took place in me when I got to that place.
That's awesome. I think getting better at that has definitely made my marriage a lot better, right?
Lots of benefits in life with it.
We're like, I'll have a thought or I'll have an emotion, right? Because the emotion almost like happens like so quick that I'm not aware of the thought.
Right.
And then I get better at sort of not saying something I regret or acting like a big baby, like I sometimes do. And then afterwards realizing my reaction was a byproduct of some distorted thinking that I don't actually agree with when I stop and look at it. My wife will tell you I have not mastered the not making a face part of it. But, because she's pretty awesome, she is pretty good at sort of accepting. And we've had, I think one of the fun or maybe not so fun parts of being married to a therapist is that I talk about how, my brain was having a moment there. I'm really sorry. My brain was telling me one thing, but I realized that like maybe I don't exactly agree with my brain. And so she'll in her good moments, she'll be like, oh, that's cool. And other times it's like, oh, you're therapizing again.
We're all works in progress. But
yep, exactly.
Any other challenges that you see in working with this population? Any common concerns or questions that come up a lot in our demographic that our listeners may want to hear about?
One of the things I see a lot is how do I respond to people who don't respond kindly? Right. I think that's a difficult one. And there is no right or wrong option, right? That I do try and let people know it is not your obligation or responsibility to educate others. But, when people do stare, it's uncomfortable. And I know all of us would wish it didn't happen. I wish everybody would automatically assume when somebody is blurting something out or perhaps having some sort of motor tic that might look odd to somebody. I wish everybody would make almost the automatic assumption this person might have a tic disorder. No big deal. I can just ignore it. But not everybody knows what this is. This is actually why I'm really passionate about going out and educating other people about what Tourette's is, right? Because I think slowly but surely we make the lives of people with Tourette's a little easier. What's nice is when I first started giving presentations and teaching about Tourette's, people were kind of starting to hear about it. And now I've reached the other end of the spectrum where most people know what it is and they just want to know more about how to be helpful.
Yeah, I noticed a lot too, that evolution in it.
Unique challenge is that a lot of psychiatric disorders are sort of invisible, right? We don't always know that someone is struggling with depression or anxiety, right? Their OCD isn't always terribly visible, but I think Tourette's is often on public display. And so what's the best response? I don't know that there's a solid answer for that other than let's figure out what the best response is for you, right? And so sometimes it really is. Some folks are super good at just radical acceptance. I get that they think it looks weird. I don't think I'm doing anything wrong. Yes, I might feel uncomfortable or embarrassed, but that's not my problem. That's theirs, and they'll be okay. Some of these folks that I work with, a lot of members of the Tourette's community are like the most sensitive in a good way, right? Compassionate, empathic people who it's kind of almost amazing. Like their thought is, I don't want to make other people uncomfortable. Yeah. And it's so sweet. It's so lovely to sort of think that way, but we can say, maybe we'll just sort of accept that it's not your fault if they do experience a moment of discomfort and that whatever it is that they're experiencing, like all emotions, are temporary. So we don't have to concern ourselves too much. But again, if we want to be preemptive, we can explain, right? I've worked with parents who do things like when their kids get on an airplane, they might take a moment to talk to the folks sitting near around them or even like give them a little card or something that explains, hey, my child has Tourette's. He or she may be making some sounds or having some motions that might be distracting. Please understand that it's not their fault and do your best to ignore them. Or if need be, even let me know and we can figure out how we can work this out together, right? Mm-hmm. I've had lots of parents do those things, ideally with the child being on board with that. And it gives them a permission structure to simply just be present in a place and understand that if I do tic, hopefully most people around us will be understanding and kind and just ignore it. Or if, maybe they're trying their best to ignore it, but they're getting annoyed or frustrated, that's okay too. This flight isn't forever. Eventually we'll all get off the plane and they'll move on with their lives. And it's most likely not going to be the thing that ruined their vacation or even ruined their day, even if it was for some short period of time I had to endure some mild frustration or irritation. So I think that's one of the big unique challenges of working with folks with Tourette's. The other one I think that is really common is that fear of will I or my child be able to have normal relationships? Will they be able to be treated fairly when they're looking for a job, right? Or interviewing for a position? That's a really legitimate concern, which is why, again, I think as early on as possible, teaching folks with Tourette's to be comfortable sort of explaining what it is even. And I know people often think it's corny, but to talk about how, living with stuff like this can be very character building, right? Can build greater empathy, can prove great resilience. Some of the most cool and amazing people I've met, and before we kind of went on microphone, we were talking about the Tim Howard Academy that the New Jersey Center for Tourette Syndrome does. And some of the best humans I've met have been at that conference, right? Yeah. These are kids who were so much more courageous than I was at their age, right? Who were just natural leaders. And I know it sounds like I'm trying to look for a false silver lining, but I genuinely believe that sometimes having Tourette's almost forces you to be more public than you originally would have been. It kind of might bring out some of those leadership qualities, or it might force you to sort of be more out and open. And I think the kids who manage it really well, they're the ones who are just battle tested and they can handle anything. And so to being able to share that story proudly with potential employers as part of your college essay, I don't think it's using your disability or your disorder. I think it's speaking your truth.
Exactly. It's your experience. It's your life. And nothing wrong with writing about it. That's a very genuine, authentic topic to pick.
For the most part, I think folks with Tourette's, I'm not going to lie to you, there are some people who would not choose to not be friends with somebody just because of their own ignorance or their own discomfort. But I also don't think it's completely disqualifying. And so those who kind of despair at the idea that I'll never make friends, nobody's ever going to give me a shot, I have never known that to be completely true if the person is willing to overcome some of the anxieties and push through and take some risks. There's always somebody out there who's kind. There's always somebody out there who's just not going to care, who's going to ignore it. So I think helping them face those challenges as well are really important.
You'll find your people, your circle, your allies and all of that around you. Yes, there's people that are just jerks. There's also a lot of it comes from a place of not knowing.
Right.
And, if you see a motor tic or you hear the vocal tic, it may look odd. It looks unusual. It's not something we see all the time. It's only weird when you don't know what it is or they don't have a name for it. It's only, that's what it in their head. They're thinking, what's going on with that guy?
Or you're just not used to it yet.
You're not used to it. You haven't acclimated to it. There needs to be some kind of explanation for it. And then it suddenly becomes oh, okay. Now I have something about it and put that anxiety at ease. It's whatever. If they're a decent person. And oftentimes, I like to assume most people are. And my advice for those kids or those, people looking to get their first job out of college and stuff, and they're concerned about how others might view them, an employer, a potential colleague. I think the more we can be proactive and kind of own that conversation ourselves, one, yes, it's empowering, but it also can help you because you can kind of control that narrative and give them some kind of assurance or something. Not that you have to do this, like we said, it is your choice, but it can definitely work in your favor. I think a lot of the bad reactions we get come from people just not getting it.
I sometimes almost refer to it as a sort of jerk filter, right? And maybe that's being a little unfair because, we're all trying to find our tribe, as you mentioned earlier, right? We're all trying to find the people we fit in with. And I don't know about you, I want to find the people who are accepting, who are open-minded, who are kind, right? So to me, we can even say having something like Tourette's, that's the most efficient way of ruling out the folks who aren't kind-hearted, who aren't as understanding, or who might just need more time than we're willing to invest to teach.
That's a really good point. It is that filter. And if you you do your disclosure speech and they're still not having it, then there you go. That's a person that shouldn't be in your life.
One of my best friends growing up had a pretty significant stutter. And when I first met him, it's not that I chose not to be his friend because of the stutter. I was aware of a stutter, and we didn't quite have a friendship yet. And I remember, this is funny, he had laser tag. He's the only kid I knew who had like a home laser tag game. I don't think he was the cool kid, but he was the like normal kid like me who stuttered pretty badly, but like, all right, I want to see what this laser tag thing is about. Right? So I'd hang out with him, and then like that was almost his foot in the door, or luckily my foot in his door, because, you know, I kind of quickly saw this guy's really witty. This guy's so smart. He's got a super cool family, amazing dude. And like, we became super close friends for many, many years. And it's not that his stutter went away, but it's just how much I cared about it disappeared. Versus when I first met him, you know, if you asked me like about him, I'd be like, oh yeah, the kid who stutters. Right. Mm-hmm. And then he just became my best friend who just so happens to stutter, but it's like the 10th thing I would use to identify him.
Not on the forefront of the list there. It's funny. I had Jeremy Lichtman and his father, Jeff and Jeremy, were both on the podcast a number of episodes ago. And I remember I was asking them about what advice do you have for parents of newly diagnosed children. And I think it was his father, Jeremy's father, that said something to the effect of have cool toys. You know, so that way when your kid's birthday party, you know, there's something else there. Then they see, oh, great guy, you know, great friend. I want this person in my life.
Yeah.
Well, Dr. Zambrano, it's been great having you on the podcast. Thank you again so much for joining. I like to end these episodes by asking my guests if there's any advice you have for the Tourette community, and the floor is yours to give anything. I know there's so many answers to that question.
Sure.
I'm curious what kind of comes to your mind here.
I mean, I think probably a little bit of some of what we already talked about, but I genuinely feel it really is so important for folks to sort of be open about the diagnosis, right? To be able to say that this is something you live with and that you get to decide on what terms you live with it. When you know that this is something you're afraid of, you know, in other words, what are people going to say? What are people going to think? Then maybe we pivot in the other direction and say, you know what, I'm just going to be open about it, that I don't have to act like this is a thing to be ashamed of or a thing to be hidden. This might be a thing that's frustrating. This might be a thing that people have to learn to ignore. But, you know, I think people of goodwill, and they are everywhere, will, you know, make peace with your symptoms, and that it's, you know, if not, then that is their problem, right? That isn't a sign that there's something wrong with you. There is something that is different about you, and that's okay. And to sort of go beyond that, to be able to say that this really does have the potential to be shaping in such a positive way for you. Again, building that resilience, building that courage, building that empathy. Those are all wonderful things if we don't succumb to being overwhelmed by anxiety or frustration. Right. And I understand as a therapist, that's always easy for me to say, but I also have the benefit of having worked with this population for almost 20 years. I see it happen too often to think that I'm just lucky enough to meet all these outlier Tourette's cases. Like, most of them genuinely are fantastic kids that any parent would be proud to have, and that anybody would think like, wow, I would totally hire this person or be friends with this person. He seems great. She seems awesome. Right. So, you know, I think sort of making sure that we bolster any self-esteem issues that might be underlying, that it's okay to really sort of feel awesome about yourself, to love yourself, to be courageous and accept yourself, even if not everybody will accept you. That's okay. I think that's a powerful message that I always like to make sure that my clients walk away with.
Be unapologetically you.
Yes. Well said, sir.
You too. Well, been great having you on. Thank you again. And to all of our listeners, stay tuned. In 2 Tuesdays from now, we will be launching our next episode. Thank you so much.
Thank you.
Thank you for listening to the UpTick, brought to you by the New Jersey Center for Tourette Syndrome and Associated Disorders, empowering you to stretch the boundaries to live your best life. The NJ Center for Tourette Syndrome and Associated Disorders, NJCTS, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on this podcast. We do not endorse any recommendation or opinion made by any guest, nor do we advocate any treatment.